Can you guys see this? Okay.
Yep.
So this is actually a requested topic. I don't know who requested it, but I think it's a great topic. I would say throughout most of my career, the issue of pediatric aggression has been at the forefront of most treatment concerns and placement concerns, and it's certainly something to embrace on how to approach. So this request was to specifically talk about the beta study, but I expanded it into a little bit of how to approach pediatric aggression to begin with, and just a little bit of things I've seen. I was an emergency room child psych consultant for almost 7 years. And so I would say the vast majority of kids coming into the emergency room either presented with some risk of self-injury, aggression toward themselves, or aggression toward others as the primary reason for their emergency room visits. And currently in my role with the state, probably the number one reason we struggle to find kids placement or appropriate placement is because of history of aggression. And the challenge with aggression is it's not a diagnosis and there's no exact treatment plan on what that means. And so we're going to start by sort of making sure we understand what aggression is, getting into the details about types of aggression, because until we do that, we can't really move to understanding it. And then the beta study talks about, well, what do you do to medicate it in an emergency? So we're going to cover lots of things today. I always tell people I love questions. I think all of you probably bring different experiences and examples where I hope this may apply, but please drop them in the chat as they come up and I'll answer them as we go. I think this is a very rich and very critical conversation that matters. It matters to our kids too. So we're gonna really try to describe the different types of aggression and how do you document it so that you understand it and you can communicate it. We're gonna really talk about how to assess etiology because you really can't begin any treatment if you don't understand what's driving it, or even your differential about what it is until you figure it out. We're gonna briefly touch on both behavior mod and non-med options, especially for acute aggression. And then we're going to follow up by really talking about emergency PRN choices for acute aggression. The follow-up lecture, if you all want, is probably what do you do for long-term chronic aggression and behavior patterns. But we're not going to totally dive into that. But this process of where you start is really the same for how you manage chronic, but you got to start at the beginning. So this is the beginning, part one of a much longer discussion. So probably my number one pet peeve is that people just write the kid's aggressive and don't give me details. And I really say we need details. You have to characterize the aggression. You have to characterize the severity of the aggression, and then you have to talk about it. And so descriptions of behaviors really matter. So there are actually four specific, like researched and documented types of aggression. And they fall into these four categories. Is it a verbal threat? Are they running their mouth and saying aggressive things? Is there physical aggression directed to other people? So there's a target aggression where there's identified receiver that's a person. Is there property destruction where the identified receiver is inanimate objects or things like throwing things, hitting walls would fall maybe in that category? Or is it aggression directed toward self where the intent is to harm themselves? And this is also where sort of self-injury or recurrent self-injurious behaviors can also be categorized as aggression. So if you just say aggression to a clinician, it just gets everyone's attention that it's scary and wrong, but it really doesn't help. So if you can really think about documenting the aggression in these ways, it really, really does help. And we're going to talk a little bit about other things you can add, but the type of aggression and the description of the aggression really matters. And then we're going to talk about the etiology, but you also have to differentiate this from temper tantrums, and especially developmental temper tantrums, or and this even applies to adults. If you're talking about folks with intellectual and developmental delays, sometimes the behavior you're seeing could be labeled aggression when it may be developmental. And that's an important context too. I mean, I'm a parent. I've seen some horrific tantrums that are absolutely terrifying, scary, and people get hurt in a tantrum. But tantrums etiology is developmental distress is very, very different than actually targeted aggression. So we never want to forget the developmental context of the behavior too. We want to know the details about the aggression. We want to know when the last aggressive event was. If the child's in the emergency room, it probably was right before they got there, but we really want to know when it occurred. You want the details of when it occurred, but you also want to go back a little bit and understand the context. Was this the first aggressive behavior? Are they having aggression like with very high intensity but low frequency, or is it very, very frequent and this was just worse? So you do want to get a sense of how often these things have happened. Is this is a new event? Is this happen about once a month? Is it happen 2 to 3 times a week? Is it daily? That type of detail matters. You also want to know if this event, especially if it's presenting in an acute setting, is this event similar to previous events, or is this entirely different in the eyes of the care holder or the child? Is this new? And then when you're taking a history, it really sometimes, especially if timing is challenging, is to get in some detail when you really want to understand risk, is not just ask about this, but ask about historic risk. What's the most aggressive thing you've ever done? Or what's the most aggressive event they've had outside of this one? Try to understand, again, what's a normal sort of behavior event with maybe mild aggression, or if this is the accelerated one. And get the details. What actually happened that made this worse or different? And this is the detective work of the behavior. So if you guys have ever seen me present, you've probably seen this slide before. I think this is truly the most common slide I have ever used in talking about how to manage behavioral issues. I love the ABCs. This is kind of at the root of functional analysis and really the true root of etiological identification of vague symptoms. I can fix a behavior if I know the antecedent and I know the consequence or the purpose of the behavior. I absolutely cannot fix a behavior just by knowing about the behavior. You know, if you tell me someone hit a wall 500 times and they did a lot of damage, I can't fix it. I absolutely can't fix it because all treatment is directed at the antecedent or the consequence. And so when you hear about a behavior, you have to dig. You may not be able to dig right away, and this detective work may take longer. And when we talk about acute aggression, you might have to medicate first and investigate later, or someone's going to get hurt, and that's okay. But you can't really not investigate, or you won't ever get to the root of fixing it. So what is the antecedent? So these are the things that happen before the behavior. This could be a whole lot of different things. This could be environment. This could be the location. This could be timing. You know, is it occurring when the ADHD medicine wears off and the ADHD symptoms come back and we see it every evening? Did something particularly stressful happen that day? Did someone say something to them? Was it an anniversary response? It's okay if the person can't identify what it is. And this is where you hear people say, well, it came out of the blue. Well, maybe. And sometimes that's the caregiver perspective. But also when you dig into the antecedents, you have to balance what the kid says and interview the kid usually too at some point, because the caregiver may only be able to describe the child's external behaviors and maybe that internal sense the kid just can't communicate in the crisis. So it's sometimes you get the report from the caregiver that it did happen out of the blue, and that's okay. But don't forget to go back later and when the child does calm down or can talk about that, try to get more of an internal sense of what happened, even when the crisis passes, so that you can set some treatment goals. And if you can identify stressors, cues, that are reoccurrent, this becomes the real foundation of a lot of behavioral treatment and coping skill work, is to help identify the things before they escalate. But you always got to talk about the antecedents. The consequences also really matter. Some behaviors have purpose, and sometimes the purpose is to get away or avoid. You know, I saw a lot of kids that punched people at school, and the whole goal was to get sent home. Sometimes it was mild, like I was getting bullied and I felt unsafe at school, and this was the only way I could get home. Sometimes it was like I was embarrassed to read in class, and so I did something to get them. They wouldn't call my. I had one kid who just wanted to call their mother. When they didn't let the kid call their mother, he punched somebody, and then of course they called the mother. So, you know, like sometimes behaviors are the purpose, and so sometimes what happens after is more important. So if you constantly see that the behavior is maybe escape or avoidance, or they needed to get out of the situation, sometimes the behavior is going to solve a purpose that you got to fix because you got to correct what went wrong. So the kid has other choices about how to react. So this applies to every behavior, and it's really in the antecedents and the consequences that we deliver, especially long-term treatment. Okay. And aggression is a symptom, as is agitation. These are vague words that don't mean a whole lot as a medical professional, other than the person's scared that uses that word. And I don't want to minimize the distress that that word causes on caregivers, on teachers, but it doesn't tell us much. And it can really have a very broad diagnosis. And this is just a very small list. The first half of this list is serious medical problems, and you can have serious medical problems that cause aggression that also need evaluated, from delirium to substance use intoxication to infections to strokes to catatonia, which can occur in medical and psychiatric conditions and be life-threatening. And then at the bottom, you can see that you literally can have aggression and agitation in almost any psychiatric disorder too. So just using that term without the details really does not help much to figure out the cause. And so this is why that detectiveness is so important. I've said this before on this, and I still stand by this, but the most, does anyone want to guess in the chat? If I had to tell you, when I really dug in, and I will honestly say I would have not said this, 20 years ago. But if I had to dig in and tell you what the most common reason most kids were aggression, or what the most common diagnosis is that led to most kids' aggressive events, if I was just my own career, does anybody want to guess what I would say? Anybody drop it in the chat. Well, you're better than most audiences. Most people start thinking about aggression and they label things conduct disorder, oppositional, and that is absolutely not the answer. It actually is anxiety disorders and kind of complicated mood and trauma. So you guys were right on board, right? Because if you are so anxious and you are terrified, hitting someone to avoid a situation is just really, really powerful. So 100%. The vast majority of aggressive events is fight, flight, serious fear, and they're trying to escape. And often it is the blocking of the escape behavior that leads to the aggression. So great job. This was a psych group. I should have known that you were going to guess right. There's also some different etiological qualities to types of aggression. This is kind of biological in its split, if you want to talk about it, but we talk about types of aggression, and this is once you do that ABC. So now you have to have done the ABC to start figuring this part out. So one type of aggression, and this is the type of aggression, the covert, instrumental, or what we call proactive aggression. This is that aggression where the aggression is the purpose, like the aggression is the outcome, right? This type of aggression is to obtain power or obtain control. And this is more of the type of aggression associated with sociopathy and conduct disorder and antisocial personality, where the aggression really is the purpose. It's often to manipulate others, to fight for status, using force, threatening and bullying, carrying a weapon. This type of behavior, it's the behavior that's trying to get the attention. This type of behavior, when you think about the biologic etiology of it, is typically not as reactive because it doesn't involve that explosive adrenal response. And so when they've kind of looked at outcomes, they have seen that, often this is that calm, cool, collected kind of aggression that can be very targeted or with a purpose to truly harm or obtain goods that we think about. This is pretty rare in mental health and more related to those types of diagnosis. And I'm not going to get into the details of it, but truly proactive or purposeful aggression really does not respond to medications at all. And you probably are not going to have success if the aggression is the purpose, right? To intimidate or threaten. So if you identify that the behavior is truly on purpose or proactive, meds aren't going to really help you very much. Now, the vast majority of aggression in mental health really is of the overt or reactive quality. And that's that fight, flight, fear. You get an autonomic discharge of cranking up the the norepinephrine and dopamine system. This is that reactive trauma response where you hit fight, flight. This is that irritability response that happens when you're annoyed or angry and you can't reel in your self-control because your frontal lobe's not well developed. This is often also at the root of temper tantrums and the undeveloped brain, so you can't cognitively correct for your emotional distress or control. And so this is far more what we see. And this type of reactive kind of aggression really does respond more possibly to medications. And so if you can identify, again, some of the subtypes of it, it really does have more of a likelihood to respond. So, as said, this article that we requested to look at was really about what happens when a child shows up in the emergency room or in an acute setting with aggression. But it really does apply even sometimes to chronic aggression. But really, if you're talking about this new onset or this acute event that happened where a child was aggressive, we want to ask at the moment, why is this child agitated now? Now, before I get into this, I also do want to talk about how, comment on the assessment of aggression if you wait too long. One of the hardest things for a kid to answer is how or why. Why were you aggressive 2 weeks ago? No child ever can answer that. But we want them to as adults. I think sometimes we want to know the why or we want to know the how. When you're talking to the child need for the interview, this is an immediate interview once they calm down, because a child cannot recall, cannot developmentally handle time to give you accurate answers. And so if you don't ask the child in the moment or shortly after it happens and they've calmed down, it's not helpful. So just like the acute event, chronic events may require frequent check-ins over time, or teaching the parent how to assess it over time. Because if you're seeing a kid in your office every month and the parent wants to talk about a behavior that happened 30 days ago, it's completely going to be unreliable. The child probably doesn't even remember it happened. They may be using very primitive reflexes. They're more likely to deny it happened, and the parent's going to say they lied. And that may actually be completely developmentally within their scope of timing. And so we have to understand the developmental context of the child's ability to answer. So that's something just to recall for the chronic ones. But if they're there right now, and if they're getting aggressive right in front of you, you don't necessarily start with the talking pace, or you have to de-escalate. But in the course of this entire evaluation, there's some things you really want to dig into historically. And again, we'll talk about the meds piece. Sometimes if aggression is escalating in front of you, you may have to medicate first based on your best guess of what you know at the moment and then reassess. But if you have some time, talking about these things can really help. And for a lot of kids, actually talking about this is therapeutic. They get a chance to emotionally correct and have a different experience as you talk about it. And so while we're using this to take history, sometimes this talk, if you can get them to the point they can talk, can actually be therapeutic, because it gives them an opportunity to talk about what they could have done differently or wish they had been able to do. And sometimes I even say that at the end of the interview, if you had a chance to do this differently again, or we could have helped you, what could have happened so that next time that you start feeling this way, how can we help you faster so you don't end up in the emergency room? So this can be a very therapeutic talk as well as an information gathering talk. But we really want to know, why is the child agitated now? Where did they come from? And did something recently happen that triggered it? We really want to know if this is similar to previous aggressive events or behaviors, or if this is like absolutely new, the first time it ever happened. Sometimes they'll tell you, well, they have a history of this, but this was different. Then get into the details. Well, what was different about this one? Was it more intense? Did it last longer? Was there more injury? Or did more people get hurt? Figure out what was different about it. Triggers could be environmental. They could be psychological. Oftentimes in kids, they're interpersonal. Someone said something to them. They misinterpreted a situation. They felt bullied. So checking, about, how things go today with your friends or your teachers or your family can kind of be a helpful conversation. Sometimes they're medical. Sometimes there's a medical event, especially in kids with limited communication, nonverbal children. Oftentimes their aggression is medical. And does anybody want to guess what the most frequent medical reason in a nonverbal child is for aggression? Well, two answers: pain and pain secondary. Yeah, it is pain. Pain secondary to constipation is crazy common, right? Urinary tract infections and pain that are acute are because they cannot communicate their distress. Excellent, Alex. Um, you want to look at their med list if you have it. You know, are they already on psychiatric medicines? Um, do they do they take something daily? Have they already been prescribed an emergency medicine at home or for a behavior? If you have a child coming from a facility or a group home, maybe they already have something as an emergency medicine for anxiety or agitation that they've already demonstrated using. Uh, I think it's always important to make sure we do talk screens. A lot of times there could be a component of substance use. Sometimes, especially in kids or vulnerable populations, people hand them things. Hey, you want to try this? And they may take a smoke of something or take something because their friend said so, and they're trying to buy social capital, but they don't know the risks of what they took. So ingestions are really common. Sometimes they can't tell you what the ingestion is. And there's so many weird things in vape. You would be shocked sometimes about what people inhale on a vape that they thought was just like tobacco, and it's not. Um, Sometimes they're suffering from side effects of medications. Psychiatric medicines have horrific side effects, especially if polypharmacy is involved. You get a shift in their metabolic profile, you get a shift in their kidney clearance or liver clearance. You can bump the dose of a medicine up and be seeing a side effect. Common psych medications that cause aggression are new onset stimulants that agitated people. SSRIs can be incredibly agitating in young kids that can't handle serotonin loads. You can have horrible akathisia from antipsychotics where people just feel restless, they can't sit still. These can all be the cause of aggression too. So were there new medicine changes that happened, or run the combo on the med list to see if you have some risk of drug-drug interactions driving things up, or did they take an overdose? So there's can be lots of medical toxic substance issues to be aware of too. Okay, so that's sort of the background. I'm going to launch into this specific study. It's called the Beta study. This is actually was in the Journal of Emergency Medicine. It's really become a seminal article in child and adolescent psychiatry because really until this study was published, and this was really truly focused on the emergency room, there really weren't great consensus guidelines and even approaching emergency medications in child and adolescent inpatient units either. People kind of did their own thing. And I will still say one of the most concerning things, and I still see this every day, is the B52 cocktail that we often see. I see given to 6 and 7-year-olds. And does anybody know what the B52 cocktail is? So the B52 cocktail sort of comes from state hospitals with very, very serious psychotic disorders. And the B stands for Benadryl. So it's IM 50 milligrams of Benadryl. The the 5 and the 2, the 5 is the Haldol, refers to 5 milligrams of let me show you. Yeah, 5 milligrams of Haldol, which is an antipsychotic, also given IM, and 2 milligrams of Ativan. So they're getting this 3-shot series that's super aggressive. And really, people were doing that because when someone is floridly psychotic and paranoid, the goal actually with that is to just stop them, because they do kind of need to just stop. They are really out of touch with reality, and they need to to just sometimes get a little sleepy on you because they believe you're going to kill them, and they're going to kill you first if they're psychotic. So this was a cocktail designed to treat psychosis, provide a little sedation, and prevent an EPS reaction to the Haldol. But this was a common cocktail, and it was translated to children, sometimes in dangerous things. And people then were having, side effects to the B52 cocktail afterwards. So, really there's been very limited guidance on how to approach childhood aggression until this article came out. And it's been now widely cited as sort of a blueprint for acuity. And we're gonna talk about it and the rationale behind it. But it is, I think, also very helpful for emergency rooms, but also inpatient units and just general clinicians that work with kids at risk of aggression every day. So aggression and agitation is dangerous. People are scared and people really do get hurt. Kids can get hurt. Adults can hurt them trying to protect themselves from the anticipation of aggression. And it often leads to very distressing situations. Then youth have, and even youth that you might not believe it, get distressed about their reactions of people once they are aggressive, like people don't trust them, or they've lost trust, or they're now feared. Some kids have to embrace being feared because they can't handle the shame or the relationship strain that happens when interpersonal aggression occurs. And so when you look at some of the studies of kids coming to the emergency room for psychiatric care, upwards of 10% can need restraint or some significant intervention for aggression. So this is not uncommon. The use of restraints is also highly regulated. And, if you work in a hospital system, you have to take training on restraints and timing of restraints because people die in restraints. And so it is highly monitored. And this has really pushed us to try to avoid physical restraint and to think more about ways to treat it faster, recognize it faster, and then perhaps use alternatives like chemical restraints or medications to cease the problem. You can't approach aggression just with meds. You really also have to build in de-escalation and a lot of trauma-informed practices. I'm going to highlight those a little bit because I can't not. But you need to be doing this alongside of a medication approach. So this beta study really came out and offered at least more of a consensus for the first time on how to view this. So let's start with the non-pharmacological stuff. And these are often things that are just need to be go-tos in the environment. So if you're treating in a mental health center, if you're treating in the emergency room, you want to think about these things and have them set up and ready to go before you need them. The environment makes a big difference. How people anticipate handling it can go a long way. So of course, clear communication is really, really important. And you need to communicate directly to the child. A lot of this is anxiety, and then they get terrified. They're in a hospital. They don't know what that means. And so you can get anxiety just from being in a new setting. And lots of times people don't talk to the kid. They talk to the caregiver and the kid feels put on the side. And so choosing very specific words that the kid will understand while talking to the adult is really important. And letting the child have a chance to reflect their feelings. And if they do start talking, don't underestimate the power of your reflective and validating feelings. The kid could say, I was really angry and I punched my friend. I can see you were really angry. And you punched your friend. That's a reflective statement. You just said back what the kid did, but tells the kid you heard them. And sometimes when you don't know what to say, reflect back or validate the feeling that they had so they know you were heard. And this goes a long way to reducing aggression and frustration for all. I can't overemphasize how important those reflective statements, even if you're just reflecting directly back what they said to you, really goes a long way for them to feel that you heard them. Then once you can calm them down, absolutely, try to assess for pain, ask about pain, ask if they're hungry or getting overwhelmed. Sometimes I would go interview a kid and they were just agitated. And I was like, hey, I'm Dr. Swagger. I wanted to talk to you a little bit, but it kind of sounds like maybe you're a little bit hungry or, is there anything I can get you before we chat? They'd ask me for a Coke or something. I'd go get it. Then I'd walk in the door with the food and I was the first person they wanted to talk to, right? Because I'd met those basic needs first and help them not be overwhelmed. And you go a long way if you meet those basic noises. Some kids get triggered by a lot of stimuli, so giving them the option or illusion of control to turn the lights on or turn the lights down can go a long way again to reduce some of those things. You often want to make sure the caregiver is available. Sometimes, if the violence occurred with the caregiver, you may have to assess if it's safe at the moment for them to be in the room together, but you always want them to be nearby and available. But you may have to make some decisions about that. And sometimes just asking, like, are you in a place right now where it's okay for you and mom to be in the same room together? Or do we still need a break for each other? Just ask and give people that option. It goes a long way. If the caregiver is not at risk, really ask them, well, what's helped before? Are there things I can do right now that would be helpful? Sometimes parents are like, yeah, they do much better if they're holding a stuffed animal. All right, let's go get that stuffed animal. So sometimes they'll give you tracks. A lot of times people get in shared spaces. Psychiatric patients sometimes get in big group rooms because they're awaiting specialized care. That can be worse sometimes. So, maybe moving them to a more private place or a less stimulating place can always be helpful. You want to make sure the room is safe. You don't want, if they're still agitated, you certainly want to think about safety protocols, not have things they can throw or hurt themselves with. And then my favorite question is, before we go talk, is there anything I can get you to just help you right now? Just straight out ask and see what they say. And then tell them you're coming back. That could go a long way just to just feel like you're meeting them where they are. Okay, so we're trying these things alongside identifying if a medicine is needed. So what is really, when we think about the medicine, what is really the goal of medication when someone's agitated? The first goal is we really want it to be helpful. We really want it to target the underlying distress or the over arousal, or maybe the goal is that we just need to calm them down enough to do the interview or to do the physical exam. So the second goal could be we're just trying to get them calm enough so they don't hit you when you do the physical exam. But we still need them to talk. And then sometimes we're doing it together, right? We're saying the words at the same time we're talking about it. And sometimes I've had kids ask me for something sometimes too, like, hey, I wanted to talk to you. Is there anything I can get you? I see you have this medicine on your list that helps you. Would you like to have that before we talk? Would that help you relax? Don't use the word calm down. Use the word relax. Calm down kind of seems pejorative to a lot of kids, or they feel like they have to self-regulate. Just use words like relax. It sounds more helpful than you need something to calm down, because I don't need anything to calm down. I need you to leave me alone, right? Like, we don't want to do that. So we really want to make sure we're asking to be helpful. It's like, anything you need, anything that I can help just get you to feel more relaxed or comfortable is a good word too, before we talk about this. The most important thing is really that the goal of medicine is not to sedate them. This is the problem with the B52. You shoot them up with a lot of medicine, they pass out on you and they may sleep for hours, and then you still don't have what you need. And it doesn't really help in the long run. And sedation is incredibly a challenging feeling for people. Again, that's the goal when someone's floridly psychotic, but the vast majority of children in the emergency room are not floridly psychotic, because that sedation, and this is often from a trauma perspective, sedation is the ultimate loss of control, right? If you already have a reactive presentation where you're on guard, or you have trust issues, or you're reacting from that flight response, and I sedate you, I absolutely exert my control over you. And now you have a period of time where you had none of your wits about you, and people wake up, they've lost time, they now absolutely have a trust problem, they feel they lost time, which can be scary. They may have gotten an injection instead of being offered an oral pill, and now they have even more of a fear response about what happened. And it doesn't get to the point of that you can talk to them and they can process what happened, and you have people, if you're in the emergency room, sleeping for hours and you can't even get them out because the psychiatrist comes and says, "Well, I can't talk to them. They're asleep. I don't know what to do. I need them to wake up." And you lose time. So while that's the risk of a lot of these, that's really not the goal. We really just want to just get the edge off so they calm down to be able to talk. We do not want sedation to be the goal. So how do you pick? Okay, so there's some things to think about, um, before you choose, and some of this depends on your hospital, your facility, or what you have access to. But again, if they already are on a medicine that's on this list, you can always give half the dose of their home medicine, like, or an extra dose of their home medicine. And sometimes they're on a standing dose of something that has some calming effects, and you can give them an extra dose. It's sometimes the best. They can tolerate it. What their predictable response is. They feel safe because they know what it is, especially if they're close to being due for the dose. Offer that first. Double check allergies or reactions. Know the kid's age. Know the kid's weight. Have a sense of what the appropriate dose is before you walk in the room. The biggest problem with the B52 is it's too much medicine, especially for little kids, and it's dangerous to give them sometimes that much, and you don't need that much. So think about the dose and the weight before you go in based on that. Know what your hospital has. What can you get access to? Think about how long the medicine lasts. When is it going to wear off? Can you give it orally? Can the kids swallow pills? Do you have dissolvable or liquid forms? Is there an IV in place and you can give something IV? Are you going to need to give it IM? Think about the access issues. Know if the kid has any history of GI, hepatic, or kidney functioning problems that might affect absorption, or how that medicine is going to get processed. In the grand scheme of things, something oral is always better, because and asking about that is always helpful, because again, it gives a sense of control. Giving people control is incredibly important in a situation where they feel aggressive and they don't feel like they have control. They don't have full control, but they can choose to swallow the pill, and that's powerful. But tell them what it's for. We don't want kids just randomly taking things, right? So say something that's helpful. If they say, I would like something because I feel angry, say, this may help you feel less angry. If they say something, I need something to just take the edge off, say, this is medicine, will help take that edge off. Trying to mimic their words so they have buy-in. They know why they're taking it. You don't want to give the illusion of force with an oral medicine. Sometimes you have to proceed if you can't de-escalate someone to IMs, but if you can avoid it, you'll have better outcomes if you can offer the PO first. Sometimes if people get combative around the PO, it's okay to offer that choice. I can give you this medicine orally, or I have a shot if you'd prefer. Again, it may not exactly be a choice, but you're giving the illusion of the choice. And some people then choose the oral medicine instead of that. Forced choice protocol can be helpful. All right, so the most common medicines, this is the list of the most common medicines used acutely. And this is different than what we use for the chronic daily meds for aggression. But these are some very reasonable choices. Many emergency situations have these. Diphenhydramine is an antihistaminergic medicine, Benadryl, used for allergies, but it does have a sedative effect that just kind of can take that edge off in a pretty neutral way. Lorazepam is a benzodiazepine. Now, we typically do not give benzodiazepines in pediatric patients as a scheduled medicine, but in some situations, it can be clearly the best choice, and we'll talk about that. Clonidine is a medicine that I use an awful lot. This is one that a lot of adult psychiatrists don't think about, but is super common in kid world. It's a medicine for ADHD. It is a little bit sedating, but it blocks the adrenal response. Alpha-2 agonist is blocking that fight, flight, sweat, but it's blocking it in the adrenal glands. So I say it kind of works well because it's a peripheral medicine. It's not a cortical medicine in its effect. It's a blood pressure medicine, but it takes that adrenal fight, flight response down a little bit and is an excellent choice, especially with some of the anxiety or trauma response. Then we have antipsychotics that come in different forms that have different possibilities we can talk about using. We will share the slides after this, so you don't have to write these down. This is the table exactly from the study, but this really talks about dosing and onset of action. And I'm not going to read this to you directly, but these are the things you want to become familiar with in terms of the doses, what the max dose is for kids, and just some things to be mindful of. So we're going to talk about diphenhydramine. Again, a lot of kids have taken diphenhydramine occasionally for allergies or parents trying to get a kid to sleep. So many kids have experience with that. This is not a medicine you want to use if they're delirious. And it can be combined sometimes with antipsychotics, but you can get a disinhibition reaction from Benadryl, just like you can for lorazepam. And I don't know, if there's anybody on this call that's ever seen a paradoxical response to Benadryl or Ativan in a child. It's terrifying. They get crazy nuts, agitated, and they are the exact opposite of what you want them to be. So if a parent ever tells you my child has a weird response to Benadryl or a weird response to lorazepam, believe them, because both of those medicines do carry a bit of a disinhibition and paradoxical response risk where they do get agitated instead of calm. And it tends to happen in the younger children, older adults, and folks with developmental disabilities. So yeah, so just be mindful of that. Alex, I'll get to your question in a minute, but yes, you can. And the doses we use, it's not usually significant, but it is really related to dose. So not so much in the smaller doses for kids. All right. Lorazepam can also be combined with some of the antipsychotics, but they specifically say, and this is in adult labeling too, that you should not combine lorazepam with olanzapine or Zyprexa because it has a serious risk of respiratory suppression and some synergistic effects between those two. So while you can usually use lorazepam and diphenhydramine in combination with antipsychotics, do not use it with Zyprexa. Clonidine is the one she asked about. That is the two biggest side effects with clonidine is the hypotension that you want to avoid, and you want to avoid giving clonidine with lorazepam because of that synergistic effect too. And typically we don't give it with atypicals because atypicals also have a little bit of an alpha-2 agonist response. So you can combine clonidine with Haldol because Haldol does not have the same effects on the blood pressure as the atypical antipsychotics, but that is the biggest risk. If you're using a starting dose is 0.025, really tiny little pill, you'll break it in half. It is really quite tiny, but again, the goal is to take the edge off the fight-flight response, and it works pretty fast. So, people usually do feel something. If you give it orally, it still takes 30 minutes though. So you want to, let them know it's not immediate. But yeah, you get much up above 0.1 for most kids in a single dose, you probably start seeing some hypotension. I will say that usually you start seeing sedation before hypotension if there aren't other agents. So you usually start seeing the effects before the hypotension becomes significant. But of course, that's the biggest thing to monitor. When we talk about antipsychotics, you also are going to have risks of hypotension with those. The quality of the antipsychotics are really quite different. And this is where understanding the differences between antipsychotics kind of do matter. Chlorpromazine is Thorazine. It in very low doses actually does not have much antipsychotic effect. So if you're really trying to treat psychosis, do not use Thorazine. You won't get an antipsychotic response to the low dose, but it does have a significant sort of effect on blood pressure and an alpha-2 kind of response with a little bit of, and they're kind of dirty drugs. So you get the sedation sort of effects kind of before you see an antipsychotic effect. So you're just chilling the edge off a little bit. And again, these can be very small doses to start with orally, like 12.5 can be a reasonable starting dose just to kind of take the edge off. Haloperidol is certainly a more effective choice for acute psychosis. It's more of a cleaner antipsychotic in that it attacks the D2 receptors pretty significantly and doesn't have as much other effects on other receptors. So it does get more of a stronger antipsychotic effect. The biggest risk with haloperidol, especially if given orally, and IM is that you can get a risk of EPS. And EPS is your extrapyramidal symptoms, your acute dystonia, where the muscles sort of stiffen or contort. And it's a very painful, scary situation. Less so with IV, actually, a little bit less. Um, um, a little bit less with IV if you're using smaller doses, but if you're starting to get up to significant doses, again, above 2 milligrams, you really typically see people administering either the Ativan or the Benadryl alongside the Haldol to prevent the EPS response. So if you're really trying to target psychosis, you can combine it with the others to avoid the EPS risk, because there's nothing worse than getting an IM medicine of Haldol and then having a panic response because you're in pain from your dystonia or torticollis. Then you get an agitated person with a medical event that also needs treated and then needs another injection of IM afterwards to treat it. So can be incredibly complicated. Olanzapine, Risperdal, and quetiapine are all atypicals. The doses are on this. They all have some risk of sedation. Typically, you kind of want to avoid with benzos, and they can cause some akathisia, restlessness afterwards, but they're all available. So I'm running out of time, which I always do, but thinking about the etiology approach really determines if you're seeing one of these 4 or 5 categories. Is delirium, substance use? Is there an autism or developmental delay, or is there a clear psychiatric diagnosis, or we just don't know? So when you're talking about medical delirium causes, you really want to avoid benzos and anticholinergics because they will worsen delirium. So usually in medical delirium, you're going to try an antipsychotic. The only exception to that is if you believe there's presence of catatonia or there's actually a risk of seizures. In that case, the lorazepam is preferred. Those are the only 2 exceptions to delirium. So catatonia and seizures, lorazepam. Other causes of delirium are confusion with serious agitation. After the medical workup, you can consider different, for severe, would be an antipsychotic. Substance use, if you suspect substance intoxication or withdrawal, typically lorazepam is preferred, the exception being opiates. If they're in opiate withdrawal, you can use clonidine, which helps some of the symptoms of withdrawal, but you could also give them a dose of Suboxone or methadone, especially if they're already on it or have experience with that to target the withdrawal. That can also be helpful, but typically lorazepam is preferred. You want to combine this with some of the UTOX sort of studies. If you have somebody that's hallucinating while in withdrawal, you can combine the Haldol and the lorazepam. And we typically see psychosis, especially with cannabinoids, and sort of the meth and stimulant substance use intoxication. So you can combine that for substance withdrawal with psychosis. In developmental delays and autism, we typically urge the avoiding of benzos because of the risk of disinhibition. Oftentimes these patients may be on standing medicine you can give an extra dose of. Urge you to really avoid IMs because of triggering the fear response in these kids. But the preferred choices are typically antipsychotics, Risperdal, Thorazine, or olanzapine, not Haldol because of some of the motor risks with that one. And then clonidine and Benadryl. Again, Benadryl, you need to double check, make sure they haven't had a paradoxical response, but those are the preferred agents for that group. And then if you kind of know the diagnosis or there's some history of diagnosis, you can certainly use that to guide a little bit. Again, if there's catatonia, lorazepam is always preferred. If more of a trauma or anxiety response, my go-to is clonidine for that group. Again, you're blocking that fight-flight response. Lorazepam can be an option, but again, there's that risk of disinhibition. And a single dose of lorazepam, if you don't have disinhibition, are not going to cause substance use. But we do see some kids with substance use problems, and I have had some kids in facilities that will seek IM lorazepam because they want their lorazepam. So you just be mindful that that's not the reason they're trying to get a medicine. But clonidine and lorazepam are going to more target that. ADHD, clonidine is an excellent choice for that. Directly treats the ADHD symptoms. Diphenhydramine or Resperal could be helpful. And don't forget, if they have their ADHD medicine with them, give them a dose. Lots of times, just a dose of their ADHD medicine will take those symptoms down a bit and help. Conduct disorder and ODD, that's your more targeted on purpose aggression, really is going to probably help, honestly, with a lot of behavioral management and incentive plans for good behavior, but you can certainly use antipsychotics or lorazepam for those. And if they're manic or psychotic, you want to choose an antipsychotic plus or minus lorazepam, except for Zyprexa. Do not combine Zyprexa with lorazepam. All right. If you're not sure of the etiology, you have to sort of pick the severity. Again, less severity, we might stick with Benadryl or lorazepam. If it's severe, we're going to use more antipsychotics. I am rapidly running out of time, but we got through the medicines. We take these principles and we translate them to maybe chronic choices with long-term aggression, but that's a whole nother chat. So sorry I'm taking up to the minute, but hopefully that was helpful. Does anybody have any questions or thoughts about this approach?